So we will begin now. Good afternoon, Excellencies, Ministers, partners, colleagues, and friends. A very warm welcome to this strategic roundtable on data and sustainable financing, twin foundations to accelerate universal health coverage. This event is co-hosted jointly by the World Health Organization and the Susan Thompson Buffett Foundation. I'm Samira Asma, Assistant Director General at WHO, and my work focuses on data, delivery, and measurable impact. And it's a real privilege to moderate this important session today. And it feels like a moment when urgency meets opportunity, a moment not just to reflect, but to act, to move from fragmented efforts to shared priorities, and from parallel solutions to platforms powered by country leadership and sustainable investments. We come together today to strengthen country-led actionable data systems, expand sustainable and innovative financing, and drive high-impact actions, especially with a focus on women and girls. We are here to spotlight real-world models, solutions, and reforms that deliver real results. This is a moment of momentum. The leaders in this room are forging a new path, bold, focused, and committed to impact. It is my distinct pleasure to introduce our co-chairs, Dr. Tedros, Director General of the World Health Organization, and joining us virtually, Professor Senait Feseha, Vice President of Global Programs of the Susan Thompson Buffett Foundation. Dr. Tedros, over to you.
Thank you. Thank you, Samira. Honorable Ministers, Professor Senait, Vice President, Buffett Foundation, Excellencies, dear colleagues and friends, a warm welcome and thank you for joining us today. I thank Professor Senait Feseha and the Susan Thompson Buffett Foundation for co-hosting this important discussion. And I thank all of you, ministers, envoys, and development partners for your leadership and commitment to data and primary health care. We meet at a moment of serious challenges and real momentum. Yesterday's adoption of the pandemic agreement was a landmark moment in global health. Congratulations to all of us. And the approval last night of the next increase in assessed contributions was a significant step towards a more sustainably financed, empowered, and independent WHO. We need that same spirit of cooperation, the same energy, and the same commitment to drive forward our work to accelerate progress towards universal health coverage. Data and health financing are both fundamental components of that work, as two of the classic building blocks of health systems. And yet, in many countries, there are serious gaps in both. An estimated 36 million births a year are not registered, and less than 40% of the world's deaths are registered. In Africa, only 44% of births and 10% of deaths are registered. If deaths are not registered, we don't know what caused them, and investments to stop them can be misplaced. In countries around the world, including higher income countries, Out-of-pocket payments are still the main way that many people access care. The consequences are dire, and the COVID-19 pandemic made them even worse, as we all know. WHO's World Health Statistics 2025 report, released last week, shows that between 2019 and 2021, global life expectancy fell by 1.8 years, the largest drop in recent history, reversing a decade of health gains. Progress on reducing maternal and child deaths has largely stalled. Access to family planning is contested. In many places, safe childbirth is a privilege, not a guarantee. And women's sexual and reproductive health are under assault. Protecting women's health is essential to protecting public health. Sudden and steep cuts to bilateral aid have made the situation even worse, causing severe disruptions to health services on which millions rely. We are in a health financing emergency. Although many countries are facing serious challenges, they also see this crisis as an opportunity to leave behind the era of aid dependency and transition towards sustainable self-reliance. That's what many ministers have told me, especially the past couple of months. WHO is supporting countries to make that transition by using a wide range of tools, including health taxes, pool procurement, and public health insurance. We're urging countries to prioritize health in national budgets, strengthen data systems, and expand smart financing solutions. And we ask partners to align external financing support with country-owned systems and priorities. The countries represented here today on the panel and in the room are going to share with us today some of the real progress they have made. From expanding domestic financing to pioneering real-time data systems, many of you are advancing solutions that are scalable, sustainable, and rooted in equity. Data and sustainable financing are not just technical matters. They're political choices. They shape who is reached, how quickly, and with what quality of care. And they determine whether we progress or fall behind. The good news is the solutions are known, the evidence is strong, and the leadership in this room is real. I have met many of the ministers many times now, in Kigali, elsewhere, and here now. Today, I encourage each of you to bring forward one step your country will take this year. One action to increase domestic financing, especially for primary health care. One reform to reduce out-of-pocket costs. One measurable result on maternal health, hypertension, immunization, or another national priority. Progress is possible if we match ambition with political will. collaboration, and accountability. Health is not a cost to be contained. It's an investment in people, in stability, and in economic growth. I look forward to hearing your priorities and working together to build health systems that are just, inclusive, and deliver results. It's now my great pleasure to hand the floor to my sister, Professor Sanait Fisaha, a force of nature, a tireless advocate for women and girls, and a visionary leader for equity and impact in global health. And especially on the agenda that we are discussing today, her passion and commitment is beyond words. So it's now my great pleasure to hand the floor to my sister Sanait. Sanait, you have the floor.
Thank you, Dr. Tedros, and my sincere apologies that I could not be here in person today. It's a pleasure, as always, to host this event with you, and I'd like to extend my welcome to Excellencies, Ministers of Health, delegates, member states, and global health partners. This has been a landmark World Health Assembly with the passage of the historic pandemic treaty. A huge congratulations to Dr. Tedros for his courageous leadership and your team for their persistent efforts, as well as member states that worked tirelessly to pass it. I also want to extend my congratulations on the 20% increase in assessed contribution. Both developments show the continued critical role the World Health Organization plays in protecting and maintaining the world's health, and member states' commitment to sustainably financing the organization. As Dr. Tedros shared, the session looks to drive into two critical pillars of health system: data and financing. This session emerged from a conversation with many of you in the room that has been ongoing for the last several months. Both data and financing consistently came up as challenges stemming from the recent decline in external funding. We know there are major limitations in the way data is collected and used today. This leaves you, health ministers, with critical challenges. How can you know what to prioritize when you don't have visibility into your population's health? Financing systems have also been woefully inadequate. And it's not just the quantity of resources, it's the quality of resources. They are fragmented, delivered in parallel, and often with limited visibility for government. But fortunately, our conversations weren't just about challenges. It quickly turned into opportunities, the opportunity to use this moment to rethink data and financing in a way that best meets your needs and the need of your people. We have incredible examples around the room which we can learn from, and that is the aim for today. For example, Rwanda has pioneered real-time data monitoring, which, among other things, can identify exactly where, when, and why maternal mortality occurs. Sierra Leone and Central African Republic are finding new ways to conduct population-level survey in the absence of DHS or the demographic health survey, utilizing their own researchers. This provides models for leveraging national institutions to support population-level analysis, as well as continuous service improvement. And isn't that exactly what sustainability and resilience should look like? There are similar examples in financing spaces. Taxing four products: tobacco, alcohol, sugar-sweetened beverages, and processed food could raise trillions of dollars while reducing harmful consumption. This is the kind of leadership, for example, Barbados has shown as one of the first 10 countries to tax sugary beverages. And taxes on salty snacks will take effect next month. Meanwhile, Benin has directed new domestic resources to its community health workers program to minimize service disruption. And given the limited fiscal space in many countries, we are now having incredible conversation with the World Bank Group on how to increase concessional financing for health. I am really happy my sister Mamta Murthy is on this call, and we also have welcomed the World Bank Group's commitment to expand health services to 1.5 billion people around the world. Honorable ministers, today's session is about learning from you. We hope to leave with better understanding of the kind of solutions you are prioritizing. But we also need everyone in the room to back these priorities. For too long, global health has operated in the opposite way, with solutions designed in the halls of Geneva, New York, London, or Seattle, and just brought to countries to implement. And what makes the World Health Organization and Assembly different is that you are the ones in charge of making these plans, making the implementation plan, and being responsible for implementation as well. But internationally or not, what we know is that this effort has in the past undermined governments, the very institution mandated to lead health in countries, and we are seeing the impact today. This is the moment to shift that reality, for countries to truly lead, and for funders and development partners to start to learn how to follow. Data and financing are a natural place to start, because that's where ministers are telling us to start. And that's just not an opportunity, it's our collective responsibility to ensure we're building towards a future where health is truly accessible to all. Thank you. And Samira, back to you to facilitate this wonderful conversation.
Thank you very much. Thank you, Dr. Tedros and Professor Sanaid, for those visionary yet pragmatic opening remarks that have framed both the urgency and the opportunity before us. Let me briefly walk you through the agenda. We will begin with the ministerial panel. We have 7 ministers who are with us on the panel who are advancing bold reforms in data, sustainable financing, and service delivery. Then we will hear from our partners from the World Bank and the African Union, followed by interventions from you, from the additional countries and the leadership. If time allows, I'll offer brief synthesis to capture some shared themes, and we will close with reflections from our co-chairs. So now it's my pleasure to introduce our panel of ministers. I will start with Minister Abdel Ghaffar from Egypt, followed by Minister Sabin from Rwanda, Minister Caputo of Liberia, Minister Walcott, Barbados, Minister Somse from Central African Republic, and Minister Chiponda from Malawi, and finally Minister Dembi from Sierra Leone. So I now invite Minister Abdel Ghaffar to open the panel. Over to you, sir.
Thank you so much, Samira, and Director General, Dr. Tedros, Excellencies, distinguished delegates and colleagues. It's a privilege to address this high-level gathering under the World Health Assembly. Today as we reaffirm our commitment to universal health coverage, we must recognize that 2 levers, reliable data and sustainable financing, are fundamental to driving progress. But above all, country leadership must remain at the heart of our collective efforts. In our country, we have placed health at the corner of our development agenda. We have expanded access to essential services, strengthened primary health care, and invested in community health systems. However, without real-time quality data, policy decisions remains blindfolded. That's why we are building integrated digital health platforms and national health observatories to monitor quality and equity efficiency, and health outcomes. Financing is an important another pillar. We are aligning public and private investment with national health priorities, increasing domestic resources, mobilization, and exploring innovative mechanisms from result-based financing to digital insurance models to ensure that no one is left behind. But without what really binds these efforts together is the country ownership. And leadership is not just about setting targets, it's about making bold decisions, owning our data, and being accountable to our citizens. It's about creating a health system that reflects our realities and is resilient to shocks, whether economic, climate, or epidemiologic. We call on our partners to support national plans, align with local systems, and invest in long-term capacity, not just short-term projects. Universal health coverage is not a global template. It's a national transformation and reform, and we are ready to lead it. Let us move forward with a conviction that data informs, financing sustains, but leadership drives. And I thank you.
Thank you very much. Minister Sabin, over to you.
Good afternoon. Thank you very much, Dr. Tedros, Professor Senait, my colleagues, ministers present here, different partners, colleagues. I think this topic is very important, financing and data. But we may think that we are financing data, but I think the points being made here is how do we connect financing and data, not just financing data systems. Let me start by saying that our traditional planning in the health systems, especially in low and middle income countries, has been led by vertical disease planning processes. That is a fact. And secondly, sometimes, most of the time, led by funders' planning and priorities. And these are the challenge of the past. So what do we learn from these lessons of the past? As some of this funding unplugging together with the funding and also leaving some of the programs without any ground for sustainability and ownership that has been mentioned by previous speakers. So we've been, in many cases, forced to come up at some point to repair or to reflect when some time has been lost or delayed. But also we learned so many lessons in the past 20 years, at least in the context of my country, that has forced us to reflect, reprioritize, and grounding our systems to what we have as priorities within our means and what we can continue even to do with or without resources that are coming from outside. We need partnerships. We need to continue to work with different partners, for sure. But also we need to build systems that can stay with or without external resources. And that's where data comes in. And the power of data here is all about how do we understand the importance of building strong data systems that we help even to utilize the limited resources we have precisely. How do we invest in the right places, not sending money everywhere without necessarily expecting that a big impact. And Professor Senait mentioned the National Health Intelligence Center that we launched 2 months ago in Kigali. That is a result of pulling all these data systems together. Most of the systems built by 20-year-old, 18-years-old coding teams from our own schools, in Rwanda Coding Academy in particular, coming together with minimum assistance from professors in digital and IT. But these young people have been able to build our first national data systems that is actually driving all the sources of information now in one warehouse. We are adding artificial intelligence analytics to make it even faster and precise and better. And we found that by investing in these data systems built locally, you spend less in our programs, you save money that you can do, also invest in other areas like virtual hospital program that we are also starting using this National Health Intelligence Center. And we really want to thank our partners, including the co-host, Susan and Thompson Buffett Foundation and WHO, that with the support of partners, but supporting what we have already in our system, in our countries, we can actually spend less. It's not about the amount of money. It's how we use the money we receive in the right place and precisely, so that we also invest in something that will remain with or without external resources, even if they are stopping, any partner stopping overnight, living overnight, you can still remain and don't panic. Your system remains with the resources you have. So to conclude, I would say we as systems, as countries, we need to continue to invest within our means. We need to have precise with our data on what we should be doing, but also we need to create new ways of domestic financing, like we've been doing in the past few months, with taxing some, I would say, is a healthy tax when you tax tobacco, sugar, gambling, and other areas actually not helpful to our citizens. But at the end, these taxes are collected to invest in programs like community-based health insurance that will continue to serve so many people. Maybe I will stop here and listen from my colleagues. Thank you.
Thank you very much. May I invite Minister Kupoto from Liberia?
Professor Sinait, Dr. Tedros, Excellencies, Honorable Ministers, distinguished colleagues, partners, and friends. I'm honored to represent Liberia here today at this gathering. As we all know, the critical areas of health data and sustainable health financing are two foundational pillars for achieving the universal health coverage. Liberia's journey towards UHC is one marked by progress, resilience, and lessons learned. We have recognized that strong national leadership driven by reliable data and sustainable and predictable financing is essential building a health system. On health data, Liberia has made some meaningful strides. We strengthened our National Health Management Information System, the DHIS2, where we have rolled it out to all 15 counties in the country, and that has helped us to monitor coverage and service delivery. But when we came to Rwanda, I thought we had to start all over. So we are now trying to look at what Rwanda did. Is not going to be exactly that, but in such a way we want to model it a little bit so we can have the real-time data that we saw as it relates to the maternal health, the ambulances, those ones we did not capture. We are working with partners to capture that. But we are very aware that timely, disaggregated, and actionable data is not just a technical issue, but also leadership. And data must guide our investments and our policies. On sustainable financing, currently, as we know, the financial landscape around the world is changing. We are looking at a country-led financial model. We work along with partners and the Ministry of Finance, and we have started rolling out the revolving drug fund in our country. So we are piloting it in counties. We also currently validated a public health scheme called the Liberia Health Equity Fund. And this fund is in, if it's passed, because we have to present it to our president and be legislated. and is aimed at reducing out-of-pocket costs for the vulnerable populations. We have completed our universal health coverage framework, and is our strategic plan for 2022 to 2031. It prioritizes equitable access to standardized essential package of health services. Our community health program, we have expanded it. We have over 4,000 trained community health assistants deployed in all 15 counties. However, we cannot do this alone. We need sustained investment in data, long-term commitments to health financing, and global architecture that respects and enables country priorities. Thank you. My colleagues may now speak.
Thank you very much, Minister. May I now invite Minister Walcott from Barbados? Thank you.
Thank you, Chair. Good afternoon to all of you. Dr. Tedros, Professor Senite, colleague, honorable ministers, distinguished delegates, distinguished ladies and gentlemen. At the outset, I want to express my pleasure and appreciation for hosting of this very important roundtable on health financing and data. In Barbados, I listened to some of my colleague ministers. I believe we have a lot of catching up to do. And I've already spoken to my colleague from Rwanda before we even started. But I'll just get to it and tell you, as it relates to Barbados, like other developing small island developing states, we face the growing challenge of escalating costs in terms of financing healthcare. And this has to do with the disease profile, but also with the new, more modern innovations within healthcare. Our public health system, for many years, we were proud of it. It was based on the beverage method of financing. That is, that there was universal access to healthcare, free at point of service, and this was being covered by the taxation. Access to taxes. We were proud. We had very good records as it related to maternal and child care. We boasted, and still do, of life expectancy of 77, 78 years. But then we came across this scourge of NCDs and cancer, which is causing severe morbidity in our population, is responsible for almost 80% of adult deaths every year in my country. In addition, coupled with this, we have an aging population, which is predicted that about 25 to 30% of our population will be over 65 years by 2030. That brings additional issues in relation to the long-term care of these people. In the modern societies, I believe, certainly in Barbados, persons are not as caring for their elderly relatives. And you find that there's quite a dependency on the government to provide and the state to provide long-term care for these people. And this adds further to the strain being placed on our health budget. As it relates to government health spending as a percentage of the GDP, we have done very well. We have not reached the level of 15%, but over the last 4 years, we've averaged about 12% of GDP. But having said that, the vast majority of the services remain publicly financed in the island, and hence in order to maintain our commitment to equity and universal access, we now need to seriously address the issue of financing. In 2018, we developed a scheme called a health levy, which through the national insurance system, you would charge a charge of 2.5% of salaries. Where the employer paid 1.5%, the employee paid 1%. And these funds were diverted directly to the main tertiary health institutions. In addition, and we've leveraged fiscal policies to drive health outcomes, but also to raise income by way of taxes on cigarettes, alcohol, the sugar-sweetened beverage tax. And most recently, as Professor Senite said, it was introduced in this year's budget that within the next 2 months, there'll be taxes on salted snacks, which are being imported into Barbados. However, to address these realities, we have been reviewing our options, and I must thank PAHO WHO for providing consultants who came to Barbados, had a number of stakeholder consultations, met with government officials, finance officials, the private sector, the insurance, and civil society to examine possibilities as it relates to financial options for Barbados. The reports are in now, and the discussion is with the Ministry of Finance, and I believe I'm safe to say they're mostly ministries of health here, the issues that you have with ministries of finance when we start to discuss the matters of health insurance and all of this. But that matter, the discussions have started, and it is something that we're certainly working on. Meanwhile, we've started some efficient reforms in terms of spending in health. We've included performance-based incentives and smarter, I use the word smarter, allocation of resources for health that is trying to reduce wastage, etc. And of course, we keep talking about it, but we need to introduce national health accounts. We recognize that sustained financing must go hand in hand with timely and accurate and real-time data. And we also recognize the transformative power of digital solutions in this regard. And we currently have a very fragmented system as it relates to data and data collection. And we are now in the process of procuring, and I say in the process of procuring because we've been through the requests of expressions of interest, the procurement process, we've done the evaluation, and we've identified the health information system that we need to go with in terms of ensuring interoperability with what we have and across the entire public health system. In addition, with support from the IADB and the Pan American Health Organization, an assessment was done which identified gaps in terms of the governance with the systems that we have and the need interoperability gaps. So as far as that is concerned, I can say Barbados remains committed to universal health coverage, and we look forward to a health system which is resilient, and we recognize that to do this we will need digital transformation and indeed to identify and introduce a viable and sustainable financing system. Thank you.
Thank you very much. It's my pleasure to invite Minister Somse from the Central African Republic.
Okay. Merci.
Thank you. Thank you very much, Director General, Professor Senait, the Susan Thompson Foundation, distinguished delegates. Thank you for giving me this opportunity to share our experience in a transformative partnership which confers upon us dignity and an ability to act. We don't have a lot of time to go into details here. I do believe that our colleagues in their experience have reflected what each one of us would also want to say. But what I want to emphasize is the how of the matter. I am Dr. Pierre Somse, Minister of Health of the CAR. As you know, this is a country that is exiting a period of conflicts, 30 years of conflict, which have devastated the health system. And that is why in our country, our healthcare system is being artificially aided. It's supported by the humanitarian sector. And that's how our country has survived to this point, with relatively low state funding, especially due to the crisis we've overcome. When I was a new minister, approximately 8 years ago, we carried out research on how to evaluate the funding situation, and we realized that between 2016 and 2019, 300 billion Central African francs were spent in the healthcare system in order to reduce maternal and children's mortality. In 2019, and up until this date, our country, the Central African Republic, is one of 3 countries with the highest maternal mortality rate, and that's and we have spent 300 billion Central African francs on this in order to resolve this issue. It's not that we didn't have enough money, but how was the money used? That's what made the difference. And what's important here, that we've learned from this experience, that is what is important with regard to our country. Our partnership with the Susan Thompson Foundation and with the WHO brought about a new approach to making our money work for us. It not just gave us the opportunity to have funding for the first time. My ministry, the Ministry of Health, had cash money to use. We had funds to manage. Previously, we did have funds, but it was scattered around. We never actually saw the results of that money, and we didn't see the results of the programs at the time. But here, we now have funding that has come to us through the trust that conferred upon us by the Susan Thompson Foundation. And they took a risk to give us this funding. All of our other partners thought that our government was a risky bet, giving us money, that we would misuse it, misappropriate it, and the system wouldn't be viable. So that is an important element that I wanted to emphasize. With this funding, with these resources, we ourselves were able to collect data as we wanted to do it. We were able to collect data that we had never been able to collect before. We were able to carry out research on maternal mortality, as I've mentioned. These are studies that had never been done before, that had not been done in over 30 years. Many humanitarian partners carry out surveys without involving the government. They they make publications on the Central African Republic without our involvement. They have resources, but these resources do not involve the Central African Republic. So what I want to emphasize is the how. The money is there, but how is it used? We have studies that have been published for the first time, and now we are going to be able to take action in order to resolve the issue of maternal mortality. We will now be able to have digital systems. The DHS, for example, will have a situation room as well, where we are able to predict indicators in real time. We're able to keep an eye on these indicators. We were not able to do this before because the money didn't belong to us. We were not capable of this. What's important in the how here is leadership, absolute leadership, which has been conferred upon us, which has enabled us to use this funding, which has enabled us to enjoy our own, to implement our own creativity in this work. And that is what's important. What I want to say to you is, when there is leadership, total leadership, ownership, we had this before, but it was in theory only. It wasn't in real life. When you have that leadership, when you can define what you want to do, identify what you want to do, the results will come and the results will be felt by the population. We have healthcare action and work that is recognized and noticed by the population. Now, our information systems involve the population. The population are our epidemiologists. They are our statisticians. This information is all validated by the population, involving the health sector and the population. If this population cannot use these data, the way we work now is we involve the population in our data collection and in the results of that data collection. And this informs our leadership roles. For the first time in December 2024, the President of the Republic delivered an address to the nation and spent 45 minutes during that address on healthcare. And this was informed by our data collection. And the population was listening to this address and approved and applauded. So this is a population that recognizes that they're being involved in the process. There is a consensus on what is ongoing now. There's a momentum as the result of this leadership. And the link between funding and data collection, funding that belongs to you, that you can take ownership of, and leadership is noticeable here. And that is what enables us to manage this transformation. I'm going to give you one last example of transformation. This is a strategy that we were not able to apply until now. I was a doctor in remote locations, and in 1984, when I finished my studies, I had 10 cesarean operations cases where the mother did not survive because the mother would only arrive at the hospital after 10 days of labor. And then, as a result, the cesarean was carried out, but the woman unfortunately did not survive. I found that it was traditional matrons who took care of these women, who delivered these babies. I found these women and I trained them with the help of the state. I trained the midwives in a way in how to avoid or how to reduce mortality, how to carry out this. I wanted to do this, but I didn't have the money to do it. I didn't have the independence or the money. Once I had financial independence, I was able to engage in this work. And here, Dr. Tedros will be quite surprised, but at the time, WHO said that they didn't want to work together with midwives. They wanted to work with nurses. But at the time, we only had 4.5 midwives or medical professionals for 10,000 inhabitants. So it was insufficient. And thanks to the resources and the funding that I received, I was then able to enjoy the freedom to carry out this work. Now, we have regions where there are no longer any maternal deaths, where midwives do not have patients who die. And I'm going to conclude here on that example in order to illustrate this concept of leadership, of funding, of data collection, and how this makes a change. I thank you.
Thank you very much. Very inspiring. Would like to invite Minister Kiponda from Malawi. Thank you.
Thank you so much, Samir. And let me thank the organizers, the DG and the STBF Foundation for organizing such an important meeting and coming at the right time on issues of data and sustainability. I'm saying it has come at the right time because the changes in geopolitics, the withdrawal of aid, has exposed the huge challenges which we have. And for some of us, a country like Malawi, in fact, if you ask me what is the impact of the withdrawal, I cannot give you a proper answer because I don't have the data. I just know that I've lost about 5,000 nurses, but apart from that, what else we have lost, I cannot tell you, I cannot compute because I don't have the data. I only know that I had a very successful, robust HIV management system where really our patients, those HIV positive, they didn't have to carry with them a health passport to go to the hospital. They would just go there. You say your name, everything else comes on the dashboard, on the screen. You don't have to worry about that. But if you have hepatitis, if you have hypertension, if you have diabetes, you need to have a health passport with you. So you have one vertical program, very successful, robust, and then the rest of all the other diseases, you need to have a file with you. Unfortunately, 2023, we had Cyclone Freddy, which affected the southern part of Malawi. We had over 3 million Malawians almost displaced from their homes. You can imagine how many of them they had lost their health passports. Because this is a book. The lost houses and everything in that house, it means you have lost years and years of your health information. You had women and children in the camps where we kept them for some time. They'll come to the clinic because we had open clinics within 24 hours. They will come to the clinic. No, I was taking a medication. What kind of a medication? It was pink. Now you tell me which medicine is pink. And this is the reality on the ground. So it buttresses the point of the importance of data, and I'm so grateful to the STB Foundation. Because making decisions without data, you're doing nothing. You're doing nothing. And you can't have within the country one program very successful and the rest of them. It's not about the disease, it's about the person. And I'm so happy with the modus operandi of STBF, because it aligns with our Health Strategic Plan 3 for the Malawi government, whereby we are saying we have a plan as government, and everybody else who wants to come and assist us, who wants to come and complement government efforts, they have to align by the government's plan. This has not been the case before, and a lot has already been said by my brother, Central African Republic. We have had so many duplications, so many wastage because of having several strategic plans, several agreements. This one will come with their own way, and several systems. Unfortunately, some of the health information systems, we don't even own them. They are hosted thousands and thousands of kilometers away. You have absolutely no clue of what is happening to our information, to our data, because that is our data. It's a security issue. We don't know what is being used there. You have absolutely no say. And that is why all of us now we're like Rwanda, 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 Rwanda. Because they have total ownership of everything. And that is the way all of us now are saying, no, let's have a common position as Africa. Let's own these things. This is data. Let's own the data. Let's own everything about the samples which are taken from our people. Let's own it. If somebody wants to borrow or use it, we should be in the loop in terms of regulation and things like that. So data management, it is very important for policy making, for direction, but also it talks to the issue of sustainability as well. Because if you don't have the proper data, you end up wasting the much needed resources. And for countries like us, whereby instead of 80 USD per capita, we are at 40. We can't afford to waste any resource at all. Where we have some of us in Malawi, maternal mortality rate is still above 200. Not good enough. Against recommended by WHO that at least you should be 70. And we're supposed to reach that 70 by the year, in 5 years' time, which is the year 2030. And some of us, maternal mortality rate accounts for 14% of the national mortality rate of the country. These are real serious issues. So we cannot afford to waste anything. Even if you talk of human resource, for Malawi, we have 2 health workers for 1,000. Well, DG says at least 4 for 1,000. And some of us, we are still at 2. So we cannot afford to waste any cent at all. We need to have proper data, and we are so grateful that you have some organizations which really are focused to making a difference in a very transparent way. Very, very transparent way. They'll come to you, you sit down around the table. What do you need? We need A, B, C, D. Okay, we are going to give you so much. And when they support you, I think it's also very important, the transparency and accountability should be on both sides of the table. Most of the times, transparency is demanded from us as government, but we don't demand transparency from the ones who have come to support us. So you have pledges being pledged to our countries, and then at the end of the day, it's as if we cannot absorb the pledge, but the reality is that even that pledge did not even come through. But we have to account for it. So the way of doing things, that's why I'm saying I'm applauding the modus operandi of the Susan Buffett Foundation. On sustainability, as a country, Malawi, we are also doing a lot. We know that with these challenges, we also need to do something on our own. We have launched the health financing strategy, which we are using now. just to rally the private sector, the citizens, all the CSOs, everybody in Malawi, that we need to do something. We cannot just wait for our partners, but also cannot just wait for government. We need to find innovative ways of bringing in more financing or more funding. We can give an example of two. We have now started direct facility funding. We have done this because we have noted that, most of the facilities for countries like Malawi, whereby 70% of your people are in the hard-to-reach areas, they're in the village. And in that village, you have only one health center. And for us, from somebody to move from capital to that health center, it takes time. So now we have introduced direct facility funding. We also want to motivate them that they should also have ownership of the funding which comes direct to them. They should not like even a plaster or something. No, they need to have something which goes direct to them, and we can even hold them accountable. So we want them to also to have a sense of ownership. We have also started in a very, very small way what we're calling a drive. A drive is that whereby with our partners, we have bought a motorcycle for a facility, a health post in the village. That motorcycle, they'll use it for selling drugs. If they have a clinic to vaccinate the children, they'll use it to do that on that day. But when it's not being used for that, they'll use it to hire out. People in the village, a motorcycle is the common transport. There are no cars there. So they're hiring out and they're getting money, which is being used. It is simple, but really it is proving to be a game changer in a village setup. So we're looking at all these things, and of course we're also in the process of, setting up the health fund, which will be, used for the sin taxes like the other countries. But we just wanted to stress the point that sustainability is very, very important. In fact, the developments now have really forced us to know when we have been talking about sustainability, but I don't think any of us were serious about it. But now, because it's in the face, we cannot avoid it. We just have to, not just to talk about it, but put strategies to address the same. Thank you so much.
Thank you very much, Minister. Now I would like to invite Minister Dembi from Sierra Leone.
Thank you, Samira. Professor Sanait, DG Tedros. It's nice to come last because my colleague ministers have said everything. I think we could all go home now. But I have a few additional thoughts I want to share with you. Sierra Leone is going through a major policy shift, a major transformation. As some of my colleagues referenced before, we have these healthcare systems that are disease-based, and they are also funded through these diseases. And so everybody gravitates to the malaria program. Everybody gravitates to the HIV program. And at the end of the day, is one patient may have malaria today and may have typhoid tomorrow. So we're shifting focus from a disease-based intervention to clear patient or client-centered care. So that brings to bear all of the interventions, but around the person. And for us to look at everybody in the country, our interpretation of universal health coverage is to follow the life stages. From pregnancy, we work with the pregnant woman to ensure that they are healthy and they deliver safely. We work with the babies from 0 to age 6 years to ensure that they have all of the health needs that they require. For kindergarten, we prepare them for school. And at school, we have school health that looks at all of the health needs for these children as they go to learn. For adults and senior citizens. So you have the whole spectrum from pregnancy to senior citizens like myself. So you have a situation where my health needs are very different from the pregnant woman's health needs. So we have to refashion the health response to target this particular health group at the stage in their life. So imagine the shift from diseases now to person-centered care, now following the life stages with all of these new metrics and the multi-dimensional view of the need of the person. This requires data. This requires granular data. So we've used in the past DHIS2 to inform our interventions. It's gone all the way to district and sub-district level. We have e-registration for patients. We have M-Supply for supply chain. But at the end of the day, you need to be a little bit more granular. So I'll cite an example as an illustrative example of how data has been useful for us for micro-level planning. We developed a new app in Sierra Leone that's looking at registering pregnancies. And so when you register a pregnancy, we have a complete profile of the pregnant woman, and we are committed. We're committed to stay with that pregnancy till delivery. And so at every encounter, we look at the 360 around the pregnant woman and see what the needs are and be able to provide those needs because we have an interest in the outcome. Not a passive interest, but an active interest in ensuring safe delivery for the mother and the baby. In the same vein, we've established an emergency operations center that's linked up to the whole country. All of the districts feed into this. So on a daily basis, we know all of the pregnancies that are in my country. On a daily basis, we know all of the high-risk pregnancies and where they are. And we deploy resources to these specific locations based on the need. We've been able to reduce maternal mortality from one of the highest in the world, at 1,300 per 100,000 live births, to the last recording was about 354 per 100,000 live births, 70-something% drop. And we're dropping that even further because we want to achieve the 70 per 100,000 by 2030. So what I've described here is a shift in policy, a major shift in policy, and the value of data in allowing us to be able to get to where we want to go. We have a clear vision of what we want to do in Sierra Leone. The next issue is just financing. How do you finance all of this? And I think there are two aspects of this. One is the supply side, the actual money on the table. The second is how you use those resources effectively to get the delta that you're looking for. I think we had a situation where there's multiple funding, as all of my colleagues have been saying. It's coming from everywhere. Everybody has their own vision for how they want this money spent. Everybody has their own plans for how these funds are being utilized. And in the end, it's very incoherent, and it's not results-based. You're not looking at the overall delta for the healthcare of the client, of the patient. So what we want to do is to ensure that as we bring resources, I mean, Sierra Leone is a relatively poor country, and you know, we're grappling with a $46 per capita health expenditure. So it's a small amount of money, and we have, we're about 11.6%, 11.7% of expenditure is focused on health, but it's 11.7% of what? So we hope that the economy will grow, and that 11.7% will be meaningful. We're looking at instituting a social health insurance scheme that will allow access with pooled risk. We're looking at sin taxes to be able to raise money, but as you raise all of these funds, the important thing is to be able to deploy those resources based on data, informed by data, impacted by data, and looking at not only the data collection and the data quality, but the data analytics that you could turn around to look at how you invest around health outcomes. So we're really excited for this meeting today, and I think for us, there's a clear vision. For us, the value of the digital transformation to help us achieve the vision is very clear. The funding piece will look for all of our partners to follow 4 fundamental principles for our Ministry of Health. One, the Ministry of Health is in charge of health for the country. We've created a vision that's co-created by all of our partners, so there is a clear vision. So what we look from our partners is accompaniment. Accompany us on this journey to fulfill our vision. We also expect alignment. So we don't want people pulling in multiple directions. So if you're accompanying us, align with us. We are in a hurry. So we're working at a very, very accelerated pace. And finally, we want all of us to be accountable to each other and to the people we serve. Thank you.
Thank you very much. Thank you to all our ministers, your excellencies, for sharing such bold and practical reforms, truly anchored in country leadership, ownership, transparency, accountability, and the 4 principles that you shared just now, all being results-based and really all interested in improving health outcomes. Before we open the floor, I would like to turn to our 2 key partners to reflect on what they have heard and how they see the road ahead. First, I would like to invite Mamta Murthy, Vice President for Human Development at the World Bank, joining us virtually. And after that, we will hear from Dr. Kaburoka, sorry. I'm so sorry. High Representative for Financing at the African Union, who is with us in the room. Mamta, over to you. Thank you.
Thank you so much, Samira, and greetings to all the ministers in the room. Thank you, DG Tedros and Sanet, Dr. Sanet, for inviting me to this very important session. I believe the issues that we're discussing, sustainable financing and robust data systems, are absolutely essential for universal health coverage. Last year, around this time, the World Bank Group set an ambitious goal to help countries to extend affordable and quality health services to 1.5 billion people by 2030. I'm very happy to say that our interventions, our technical assistance, our financial support has reached 200 million people. Of course, this is a start, and there is a long road ahead, especially amidst a shifting global health financing landscape, as many of the ministers have already alluded. That's why we remain cautious about the ability to reach 1.5 billion people by 2030. But we also see this challenge as an opportunity. Many country leaders, including ministers of health represented here today, have made bold decisions, rethinking their strategy for health more fundamentally, focusing on increasing budgets for health, increasing the efficiency of spending, and thereby expanding coverage. And the twin foundations that we are discussing, sustainable financing and strong data systems, are the key to achieving the outcomes that everyone is seeking. So let me start just by saying a few words on data systems that, as many have eloquently said already, need to guide the resources where they can have the most impact based on a national health plan. At the World Bank, we are looking to support countries to modernize their data systems and use this information for decision making, exactly as outlined by Minister Dembi from Sierra Leone. Because I think we can all agree that real-time information is needed to guide decisions, starting at the national policy level, but essentially also to bedside care, so that performance can be tracked, can be measured, course corrections can be made, and importantly, decision makers at all levels can be held accountable. Let me just give 2 examples of what we're doing. In Argentina, we are supporting a digital health system to manage medical records, appointments, prescriptions, and other services. In India, we are supporting the digitalization of the primary healthcare system, and this is helping with disease surveillance, primary healthcare inventory management, preventive care for NCDs, as well as treatment. Now, let me get on to financing, which is the trickier part, if I may say so. We are supporting reforms to increase the financing available for health and the impact that the resources can have on health. And this means working with countries to understand the fiscal space that they have, but also to define the health benefit package based on disease burden and not the amount of external financing that is available. And this is behind the health insurance reforms that we're supporting. To give one example here, in Côte d'Ivoire, the World Bank is supporting efforts to scale the national health insurance system so that coverage can expand from around 10% in 2023 to 80% next year through public-private collaboration. Côte d'Ivoire is also a country where we have supported a debt for development swap. This is helping 30,000 young people in Côte d'Ivoire attend secondary school. We are really hoping that there can be more debt for development swaps, including in health. Finally, I should say that the problems of small island developing states are unique, and we are working on solutions to support sustainable financing of health in the context of SIDS. Now, let me just say that we know that this 1.5 billion target is going to be hard to achieve, and progress depends on strong partnerships that reduce fragmentation and align resources. Many of you have said this already. A couple of examples of things that are coming down the road. First of all, there's the launch of the UHC hub in Tokyo later this year under the leadership of Japan and the WHO. And this will be a platform to strengthen collaboration between ministries of health and ministries of finance. The Honorable Minister from Barbados spoke about what an important nexus this is that is essential for sustainable health financing. Another thing that we hope is coming down the road is the deployment of more co-financing to ensure that IDA, alongside grant financing, can help more countries invest in sustainable financing and health delivery reforms. This is only the beginning, but we believe there is a strong journey, a long journey, which can be a strong journey ahead. So I want to close by actually echoing the words of Minister Dembi. I think all of us as partners need to accompany country leadership in supporting expansion of health coverage and financing reforms, as well as data systems, in order to have more resources used better to improve healthcare. So please join us as we support country leadership to transform today's constraints into tomorrow's progress. Thank you very much.
Thank you very much, Mamta. And may I invite Dr. Kaburuka to share your thoughts. Thank you.
Thank you very much. Can you hear me? Thank you. Thank you, Tedros. Thank you, Senate. Thank you, ministers. And congratulations on the pandemic treaty. I think that is a historic achievement. Now, you have framed this meeting as listening to our ministers. So we're here to listen on behalf of the African Union, and I've learned quite a lot listening to our ministers. Clearly, great things are happening, as they should, and I'm glad to be here. So I'll be very brief and have just 2 points. My claim to knowledge of public health was because I spent, I think, 4 years here in Geneva as chair of the board of the Global Fund. And a long time ago, I used to be finance minister, so I was involved in allocating resources. So I have only 2 points I want to make, just 2, and I'll be very brief, because everything has been said. One of the most consequential American presidents, Dwight Eisenhower, who many of you know, a very famous president, very consequential, said things I want you to bear in mind. He said, plans are useless, but planning is indispensable. Plans are useless, but planning is indispensable. This is an American president who was a great commander and former head of NATO. And the reason he said this is that even the most meticulous plan can often fail short due to unforeseen circumstances, such as, for example, the recent cut in foreign aid. That was an unforeseen circumstances. You all had great plans. Now, those of us who are Christians know that in the Bible, there is talk about 7 very years of plenty and 7 years of shortages. So the last 25 years, we have lived in the years of relative plenty. Now we're entering a period of relative shortage. And so as you think about these issues, it's about planning in the context of less resources than we are used to. It is true in the 25 years of plenty, relative plenty, disease burden has come down, child mortality, life expectancy has come up. Now we have to maintain those things in the years of reduced availability of resources. I think that's the challenges of your planning. And the reason I'm happy you are discussing data is that you cannot manage anything without data. You can't plan if you don't have information. So the conversation around data, it means you have great understanding, you develop flexibility, adaptability, instead of having rigid plans which fall short as soon as you come against an external shock or some unforeseen circumstances. It enhances collaboration with external parties and also overcomes, Tedros, you know this, something in international organizations we call analysis paralysis. I've attended meetings in the last 1 year about what do we do about health financing. And I think sometimes we tend to this analysis paralysis. We're in a new circumstances and it's not about to change. So we need to move forward. Hopefully, in the many discussions we've had to land somewhere. There was a mini summit at the African Union about a month ago, chaired by my president, who is a champion for the AU on domestic health financing. And I welcome many decisions which are taken there on domestic resource mobilization, better public financial management, innovation. All these things are important. I want ministers of health to understand, though, that your ministers, your governments, are also facing challenges on education, on food security, and on paying debt. And therefore, even if we increase domestic resource mobilization, there will still be choices to be made within the health sector and between the health sector and other sectors. In the health sector itself and between the health sector and the other sectors. This has to be a continuous choice we'll have to make. Look, I want to say that we're prepared to work with you on this. I'm impressed by the plans I've had. But remember Eisenhower, and remember that we can do quite a lot even with limited resources. At the meeting Tedros and I attended in Kigali, which Senate thanks for convening, I gave the example of what happened in COVID. There is no evidence, none whatsoever, to say that countries with more resources in per capita terms did better at containing COVID than those with resources. Countries who did very well in COVID management, like South Korea, like Israel, like Vietnam, like my own, had probably less resources than Italy, which Italy had more resources, or even the USA. And so we need to think about how do we get more resources, more health, better outcomes for a period of limited resources. And I know that great things are being done in the countries and the WHO, and we'll be there to back you up. Thank you.
Thank you very much. I know we are at the hour, but I would really request a few more minutes of your attention, and we would like to hear from 2 countries from the floor, Minister Hung Paten from Benin and Minister Aden Duale from Kenya. A minute each, we would appreciate listening to you from your perspectives. And then I will pass on to the co-chairs for any final closing remarks. Thank you.
Merci.
Thank you. Thank you very much. I'd like to thank Dr. Tedros and Professor Senait for giving us this opportunity to have this meeting. I would like to make a few comments. Everything's already been said, but with regard to Benin, in terms of data calculation and collections, data helps us make community-based decisions, the best decisions, and that's why right now what we're building is a community-based healthcare system that is on a voluntary basis in order to ensure that the entire community, each community, can have access to information. We have 200 households for one community center, and we've got healthcare agencies as well that supervise these community centers, and this means that we have deconcentrated, decentralized prevention and healthcare promotion. And I'd like to thank the foundation for their support. This is a unique model that we've implemented with the help of USAID. We're trying to cover 22 communes out of 117. And with our government, we've put into place $200 million in order to close these gaps. And the foundation has provided us with support here in order to close these gaps entirely and enable us to decentralize these policies and continue them. I do have something else to add in addition to this. Benin has committed that in 5 years, all of our policy centers will be fully funded by local resources, and that means that that's approximately $30 million. And when I take a look at the Beninese budget for this year, that's $300,000 million. That means that will help us to covering these community centers. It's important for us to be able to build this healthcare system so that we can better reallocate these resources to have more results, especially when it comes to taking fact-based decisions based on data. Thank you.
Thank you very much. Minister from Kenya, if I may just invite you to share your reflections.
To thank WHO through Dr. Tedros and Susan Thompson Barrett Foundation for convening this roundtable discussion. Kenya is undertaking a very fundamental reforms in its health financing architecture. And we are moving from the previous National Health Insurance Fund to the Social Health Insurance Fund in order to cover the entire population. How have you done this? We have created 3 funds. One is fully funded by the government, the exchequer, and that is the primary fund to cater for services in level 2 to level 4, free of charge. You walk in, you walk out. Then we have number 2, where is the emergency chronic and critical illness fund, which caters for emergencies and when one exhausts his social health insurance cover. And the third one now, which is mandatory for all salaried people in our country, Social Health Insurance Fund, which is based on 2.7% of one's income. Regarding data, we have prioritized a digital health superhighway through our digital health agency within the Ministry of Health. And it starts from the household, it starts from the home, where we have community health promoters, all the way to the primary care networks, and all our current existing health information systems will all come under this superhighway. What does this digital superhighway does in our country? One, it tracks and traces all health products and technologies to the manufacturer. 2, we use that superhighway for telemedicine. 3, we use that digital superhighway to do accreditation and registration of all our health workers, doctors and nurses, and this helps us to weed out quacks and unprofessional health workers in our country. It also helps us to improve efficiency in resource utilization. Registration and accreditation of all healthcare facilities in our country are done under the digital superhighway, weeding out fake health facilities. And finally, we use biometrics for the identification of patients at all our health facilities. And our data, the cloud, our data is stored in our own country. And I really want to ask colleagues ministers that it is dangerous to allow your data to be stored outside your country. And finally, I think if you allow me, let us therefore use this forum to reimagine the global health financing and the data architecture, not just to meet targets, but to serve the people. Let us co-create models that will embed accountability, equity, and country ownership at the core. Together we can deliver a future where universal health care is a reality for all our citizens. Thank you.
Thank you very, very much. I understand that many of you have to join other meetings, and we are really running short of time, and we have some requests from South Sudan and Burkina Faso. So half a minute, if I may please request you, and then I would like to pass on for closing remarks to DG and Professor Senait.
Thank you so much. South Sudan, not South Sudan. I'm Farouk Noordaim Umar, Director General of...
I am the Director General of the Healthcare Insurance in Sudan. Due to the war in...
of finance for defense budget, which challenging the health financing allocation. This situation actually need different tactics and interventions for more resilient health system and more resilient health financing. So these tactics and interventions begin. Well, now we begin with the reforming of revenue collection towards earmarked tax and shifting the NHIF, National Health Insurance Fund, from premium-based to tax-based. Secondly, so the health financing pooling by investing in data which will absorb new demographic changes in my country to achieve equitable and efficient allocation which lead to equitable distribution of health services. Third, reforming of the procurement of services towards strategic purchasing and inclusion of private sector. Finally, I recommend digital system to manage health financing through cross-border countries data like, for example, OpenIMS and DHIS sponsored by WHO. Thank you.
Thank you very much. My apologies, Sudan. Thank you for those interventions. A quick response from Burkina Faso, please.
Alors, merci beaucoup.
Thank you very much. I'll be brief. But I'd just like to continue on what Dr. Tedros has said, that healthcare is more of an investment for development of life. That's of paramount importance, and we align ourselves with that. In Burkina Faso, our president truly shares this vision. This is a country that is suffering from terrorism, a country that has suffered from a lack of funding, the cessation of funding from a bilateral partnership, and 12% of our state budget is allocated towards the health ministry, despite the humanitarian crisis, despite the situation. So that is something that's important. And it is this funding that enables Burkina Faso to respect its commitments. 95% of our commitments taken with the Global Fund in the framework of funding has been respected. With Gavi, we have also paid back what we owed, and that was $10 million. So in 2025, there's nothing else to make up for. And this funding enables women in our country, even in rural areas, to benefit from mammograms, cancer screening, not just in Ouagadougou and the other major cities, but in rural areas, they're able to do screening and mammograms, and that is free. Please note it's free. A second thing that I'd like to mention is that we have implemented what we call a digital minimum ecosystem, which provides information solutions, digitalized solutions that improve efficiency. And we have implemented that, and it has enabled Burkina Faso to reduce by 17% any fees related to healthcare for women and people under 25 years of age. We are improving our efficiency and allies with partnerships. We've on our plan and our budget. I'd like to also thank the Buffett Foundation for their flexibility and their understanding, because this is a foundation that trusts Burkina Faso, that is providing funding through our treasurer. And this is what I would like to share with you. Thank you very much.
Thank you very much indeed. And I would like to now invite our co-chairs to offer your closing reflections. Professor Sanait and Dr. Tedros, over to you.
Thank you, Samira. Thank you, Dr. Tedros. All the ministers that were in the panel and our partners from the World Bank Group, Mamta Murthy and Dr. Kabaruka from the AU Special Envoy on Health Financing. This is clearly a conversation where we have only scratched the surface, but in closing, I want to highlight a few points we can take away. The first is the clear call around country-designed, developed, and owned data systems. WHO support will be key here to ensure global comparability while supporting national level systems. So, Dr. Tedros, I know we can count on you and your team to accompany countries here. And I know Samira Azma, who's been the force behind the WHO data and delivery for impact unit, the World Health Annual Report and the measurement of GPW 13 and 14 has agreed to champion this initiative, working with the Buffett Foundation and the WHO. So we very much look forward to supporting countries on this initiative. Second is on the how of partnership. There is a lot of lip service to country ownership, but I think we've heard what that really looks like today, and I'll use Minister Dembi's words: accompaniment, supporting national plans, aligning to local systems, and building national capacity. And on financing, I think we have an incredible opportunity. Dr. Kabaruka has clearly outlined the challenges that are not only in health, but in other sectors, and countries continue to struggle servicing their debt. However, despite that, we're going to focus on efficiency, better utilization, but also finding corners. And we look forward to working with the bank and using the upcoming UHC Hub launch in partnership with Japan, the World Bank, and the WHO as a deadline to hopefully bring a few countries along on a compact agreement along with the bank to increase financing. And lastly, one other comment I will plug in is we are also working with Tom Frieden and his team. We just started in Zambia, where they're providing technical expertise for countries that are looking to expanding into health taxes. So in partnership with WHO and other implementing partners, the foundation will be more than happy to help some of these financing initiatives as well, in addition to directly funding government. And I think lastly, on leadership, the Egyptian minister said it's best. Leadership drives. Despite all the challenges, I think the future is incredibly bright because of those of you that were in the panel, as well as all of you ministers who are in the room. So we very much look forward to working with you. Thank you for joining us, but thank you for showing up every day for fighting for better health and a better world for the world. We look forward to accompanying you on this journey. Thank you, and thank you, Dr. Tedros and the WHO for co-hosting with us. Samira, back to you, or Dr. Tedros, if you're going to take it and close us out.
Thank you, Dr. Tedros.
Yeah, thank you. I think we're very late, so I don't want to add anything. I fully agree with what Senait said. And the only thing I would say is thank you so much and time to act. All the best.
Thank you. Thank you very much, everyone. Have a good afternoon. Thank you.